Hello everybody. Today we will discuss clinical biochemistry. I am Jayanti Reddy, Associate Professor from G. Pullareddy College of Pharmacy, Medipatnam, Hyderabad. Clinical biochemistry. Biochemistry is a science concerned with the chemical constituents of living cells and with the reactions and processes they undergo. Clinical biochemistry deals with the biochemistry laboratory applications to find out cause of a disease. The chemical constituents of various body fluids such as blood, urine, cerebrospinal fluid are analyzed. These determinations are useful in diagnosing various clinical conditions such as diabetes mellitus, jaundice, gout, hyperlipidemia, pancreatitis, rickets, etc. The biochemistry tests are useful in determining the severity of disease of many organs such as liver, stomach, heart, kidneys, brain, as well as endocrine disorders and related status of acid-base balance of the body. The clinical biochemistry tests in relation to various clinical conditions can reveal the cause of the diseases, screen easy diagnosis, suggest effective treatment, assist in monitoring progress of a pathological condition, and help in assessing response to therapy. As a part of clinical biochemistry, urine analysis has a vital role to play. Routine urine analysis is mainly performed for two purposes: to find out metabolic or endocrine disturbances of the body, for example, bilirubin and glucose, to detect intrinsic conditions that adversely affect the urinary tract or the kidneys. Diseased kidneys cannot function normally in regulating the volume and composition of body fluids and also in maintaining acid-base balance and hemostasis. Consequently, structural elements such as leukocytes, red blood cells, urinary tract cells, and gas from lower urinary tract may appear in urine. Substances normally retained by the kidneys or excreted in small amounts may also appear in urine in large quantities. And substances normally excreted may be retained, which is indicated by their increased values in blood. To identify various diseases, qualitative and quantitative urine analysis is performed. Qualitative tests the presence or absence of abnormal constituents like glucose, protein, ketone bodies, occult blood, bile pigments, bile salts, and urobilinogens. Qualitative urine analysis for abnormal constituents. First is determination of glucose. The clinical significance is that the presence of chemically detectable amount of glucose in urine is called glycosuria or glucosuria. The quantity of glucose that appears in the urine is dependent upon blood glucose level, or rather the blood sugar level, rate of glomerular filtration, degree of tubular reabsorption. The other conditions are myocardial infarction, cerebral hemorrhage, brain tumors, severe liver diseases, and whole organ disease of the pancreas. Glycosuria may occur due to defect in reabsorptive ability of renal tubules and subsequent lowered renal threshold. Tubular defects can also be due to cystinosis or heavy metal poisoning. Other non-pathological conditions which result in glycosuria are pregnancy, stress, and anxiety. The method used is Benedict's qualitative test. Principle of this method is glucose present in urine reduces cupric ions present in the reagent to cuprous ions in hot alkaline medium. For the procedure, you have to take 5 ml of Benedict's qualitative reagent in a test tube and add 8 drops of urine. Mix and boil for 2 to 5 minutes. Note the change in color on cooling. If the color is retained blue, then we can say that the sugar is absent. If the solution is green and having a slight yellow precipitate, then trace amounts of sugar is present. Green solution and thick yellow precipitate can be sugar present from 1 plus to 2 plus gradation. Yellow color and with orange precipitate, the sugar content is 3 plus. Orange color of the solution and orange to red precipitate, the sugar present is plus 4. The next comes the determination of protein. The clinical significance is that the presence of chemically detectable amount of protein in urine is called proteinuria. This occurs due to glomerular damage, defect in the reabsorption process of the tubules. In glomerular damage, capillary walls become more permeable. Proteinuria is due to pre-renal, renal or post-renal conditions. Glomerular proteinuria may be due to glomerular nephritis, hypertension and lipoid nephrosis. In diminished tubular reabsorption, low molecular weight proteins are not completely reabsorbed and hence are present in urine. The related conditions are pyelonephritis, renal tubular acidosis, cystinosis, interstitial nephritis, and rejection of kidney allografts. In post-renal conditions, proteins may be added in urine as it passes along the urinary tract. Lesions of the renal pelvis, bladder, prostate and urethra can also lead to such condition. Method used is sulfosalicylic acid test, where the precipitation of protein by sulfosalicylic acid takes place. You have to take 3 to 4 ml of filtered urine in a test tube. Add 2 to 3 drops of sulfosalicylic acid on the top of the specimen. Observe for turbidity after 5 minutes. If no formation of turbidity at the upper portion of the urine, then the protein is absent. Formation of turbidity indicates presence of protein. If proteins are present, grade the result according to the degree of turbidity as trace, +1, +2, +3 and +4. Another method used is heat coagulation method, where the proteins are coagulated by heat. For this, the procedure is you have to place 5 to 10 ml of clear urine in a test tube. Boil the upper portions over a flame. If the turbidity develops, add 1 to 2 drops of glacial acetic acid. If the turbidity is due to phosphate precipitation, it will clear. Reboil the specimen. Observation after reboiling the specimen. If there is no turbidity, then the proteins are absent. Presence of turbidity, proteins are present. Grade the degree of turbidity as mentioned above. Then comes the determination of ketones. Wherever there is inadequate carbohydrate in the diet or a defect in carbohydrate metabolism, the body tends to metabolize increasing amounts of fatty acids. Due to this, the other intermediary products such as ketone bodies also increase in blood. These are acetone, acetoacetic acid, beta-hydroxybutyric acid. Diabetes mellitus is the most important disorder in which ketonuria occurs. Ketonuria may also occur in conditions like anorexia, fasting, starvation, fevers, and prolonged vomiting. The method used is Rothera's test. Principle involved is where nitroprusside reacts with acetone acetoacetic acid in the presence of an alkali ammonium hydroxide to produce a purple colored complex. Take a pinch of Rothera's mixture in a dry test tube, add few drops of urine sufficient to moisten the powder. Observe the color change after a minute. No appearance of pink-purple color, ketone bodies are absent. Appearance of pink-purple color, ketone bodies present. Light pink is trace, pink indicates +1, dark pink +2, light purple +3 and dark purple +4. Determination of bile pigments, bile salts and urobilinogen. The determination of bile pigments, bile salts and urobilinogen is useful in the diagnosis of jaundice. Icterus or jaundice refers to the yellow pigmentation of the skin, conjunctiva and mucous membrane by the abnormal increase of bilirubin in blood. This may be observed in prehepatic, hepatic and posthepatic conditions. In the intestine, bilirubin is converted by bacteria enzymes to several related compounds collectively called as urobilinogen. Most of it is lost in feces as starcobilinogen. The method used is Harrison spot test. For bile pigments, when barium chloride reagent is added to urine, it combines with sulfate radicals in urine and precipitate of barium sulfate is formed. If bile pigments are present in urine, they will adhere to these large molecules. Ferric chloride presence in Fauchett's reagent then oxidizes yellow bilirubin in the presence of trichloroacetic acid to green biliverdin. Urobilinogen reacts with para-dimethyl aminobenzaldehyde in acidic medium to form pink colored complex. You have to take 3 to 4 ml of urine in a centrifuge tube, add equal amount of 10 grams per dl barium chloride, mix well. Centrifuge at 1500 rpm for 10 minutes or filter by using Wattmann No. 1 filter paper. Transfer the supernatant into another test tube for urobilinogen test. Add 1 or 2 drops of Fauchett's reagent to the sediment or to the precipitate on a filter paper. Add 0.5 ml of Ulrich reagent to the supernatant. Of the sediment, when you observe, when there is no change in color, bile pigments are absent. Change in color to green, bile pigments are present. Grade the positive results as trace +1, +2, +3 and +4 according to the intensity of color of the sediment. For the supernatant, development of pale pink color indicates urobilinogen presence, which is normal. Development of cherry red color, urobilinogen increased. Grade the results according to the intensity of colors. The determination of bile salts. The bile salts, when present, lower the surface tension of urine. When sulfur powder is added to the surface of urine, sulfur particles sink to the bottom of the test tube. For the procedure, take 10 ml of urine in a test tube, sprinkle a pinch of dry sulfur powder onto the surface of urine. Observe the sulfur particles. The sulfur particles sink to the bottom, bile salts are present. Sulfur particles remain floating, the bile salts are absent. Thank you.